Welcome to LollieTasking with ADHD. I am your host, Dr. Lola, a multi-passionate mom of three, a physician, and an ADHD life coach because, like most of you amazing women listening, I have ADHD. Join me as we chat about how ADHD affects our lives and learn strategies to help us all thrive, not just survive, with ADHD so we can live the life we want while accomplishing all our goals. Let's get started. Hello, LollieTaskers. Again, I'm Dr. Lola. I'm your lifestyle strategist and ADHD trained coach. I love to help easily distracted women with ADHD, or any women actually, to help them achieve their goal, either because their brain is sabotaging their effort or they're just overwhelmed by life. And welcome to LollieTasking again. So today I have an amazing guest with us. When I was reading her bio, I was like, Her name is Dr. Bolanle. Dr. Bolanle is a psychiatrist and a life transformation agent. When I read that, I was like, wow, yes, transform my life, sis. She is the C.M.O and founder at BrightMindsMD, a private psychiatric practice in New Jersey. There, she offers a unique and whole person approach to treatment using a hybrid of medication and lifestyle and behavioral modification. And when I read this, I was like, yes, because this is what I preach. Her treatment perspective looks at the contribution of childhood experiences, environmental stresses, genetic predisposition, and co-occurring illnesses, nutritional deficiency, activity level, and so on to help you. Dr. Bolanle is passionate about spreading the message of mental wellness and making it accessible to all. She is a mom of two amazing children whom she enjoys exploring life with together with her husband. When she's not at work, she enjoys time with her family, traveling to experience new places, dancing, writing, and secretly enjoys good Yoruba speaking movie productions. Wow. Welcome to the show, Dr. Bolanle.
Thank you. Thank you for having me. I'm glad to be here.
It is so amazing to have you. And, when I was thinking about October is like ADHD Awareness Month. And I was like, who else to bring as our master coach or to the show if it's not someone who knows it front and back? And I thought, why not bring a psychiatrist? And I'm so happy you have agreed to join us today. So before I get started, I love to learn about you and what your journey is with ADHD. How did you fall into ADHD? I know you're a psychiatrist, so you do all sorts of things, but given that this is LollieTasking with ADHD, we wanted to make it more focused. What's your love for ADHD? Why do you love us? Why do you like to treat us? Just go into just a little bit, and then we'll kind of go from there.
All right, sure. Thank you. So I am a psychiatrist. I mean, like you mentioned, psychiatric diagnosis or disorders are my focus. But I'm adult trained and not child trained. So ADHD used to actually be the purview of child psychiatrists when we were in training. I would say that when we did our adult training, we got very minimal exposure to ADHD, and only in our child rotations did we really kind of get some kind of exposure. It wasn't something that, we focused more in adults. However, in adult practice over the years, I find, and many psychiatrists are finding, that there's increasing awareness with ADHD and more women being diagnosed with ADHD or, identifying with symptoms, the overwhelm, the frazzled, the things that come up as women go through stages in life. So it became imperative to start paying attention to ADHD, diagnosis of ADHD. So I had to go through a process of re-education in how to pick up adult ADHD, what to do about it, treating it, legitimate diagnosis that impacts the life of women patients as they come along. And I wouldn't even call myself an expert. I wouldn't dare call myself an expert yet. It's still a learning process. There's so much that is being uncovered, but it's been, I would say, exciting to learn more and more about this diagnosis, what it means and how it impacts people and how to help people live with it, overcome it.
Oh, I'm so glad you say that, because I'm a pediatrician, first of all, before a pediatric cardiologist. And even in training, when they were teaching us about ADHD, and I was telling people, when I was in medical school and they told me I had ADHD, I was like, No, I don't. I'm not the young little girl that's bubbly in class. No, I don't, right?
Right.
Because what they taught us in medical school is so different. So there's sometimes where I've had clients say, my psychiatrist does not believe I have ADHD. And it takes a psychiatrist being open-minded. And like I tell people, medicine evolves. They
Right.
may have been telling you based on what they knew, right?
Right.
But
Right.
as new studies come out, as new things change, medicine evolves. And that's why we call it the practice of medicine.
Absolutely, absolutely. And we also have to know that a lot of people, so the old DSM criteria, which is what I was, it was DSM-4 when I was in training, you know,
Yep.
a lot of the criteria required diagnosis, I think before the age of 12 used to be the
Yep.
cutoff. And now we know that a lot of people may not have been diagnosed before 12, especially women, because women didn't have the hyperactivity as much as men. ADHD, in fact, used to be considered a boy's disorder. So a lot of women will compensate by being, you know, women are usually people pleasers, so they didn't get in trouble in school. They overcompensated in class, so they were never picked up. And the teachers really don't notice the girl that's daydreaming and outside the window as long as they were, you know, managing. Whereas boys
Getting
who
good
were
grades,
getting
right?
good grades, right? But boys who were disruptive, you know, chatting to everyone, pulling out chairs, that's who got attention, that's who got referred. So there was a difference in who got referred as well, which is why, you know, the old system of saying, well, if you weren't diagnosed until you were 12, that means you don't have it, doesn't really pan out, because then when life's load or burden became more tasking, people who weren't diagnosed before were coming to light. And so what do we do with them? Oh, because you didn't get referred early, that you're done.
Right? AKA me. So that's actually a good point. Like I was in training during DSM-4 too. And I remember when they said, I think you may have ADHD, I was like, no, I took totally, and I was a nerd, you know me. I totally like took out my DSM. I was like, nope, I don't meet this, I don't meet this, I don't meet this, I don't meet this. And I went to a neuropsychiatrist and it was like, no, you have severe inattentive. Yes, you do have ADHD. So here's the thing. So what are we on now? Because I'm not gonna lie, I have not done psych in a while. Are we at
Just five,
DSM-5?
just
Okay,
one. Yeah, it
6.
takes
So
them a
we're
few
still at
years. We're
DSM-5.
still 5. Yeah, we're still at
Okay,
5.
perfect. I'm still a young kid. Okay, I was like, wait, are we on 6 already?
No, 5. It takes
Because
them a
I
few
remember
years.
4 just came out when I was in training. Okay, so DSM-5. So what is the criteria based on DSM-5? You could just give us a summary.
It's still similar to 4. I think they just expanded it out a little bit. You still need to have like at least 5 symptoms of inattention or hyperactivity. But then the other criteria would be that they need to be present. Well, they still say that symptoms of it should be present before you're 12, but not necessarily diagnosed before you're 12.
Right.
You need to have it, these symptoms present in at least 2 domains. So maybe work and school, school and home, you know, like overlap of different settings. There needs to be significant impairment in some of those domains in terms of how it impacts life. And the 5th criteria now is that it can be accounted for by other diagnoses. So it's still pretty similar, but expanded and made a bit more encompassing. And even the thought leaders on ADHD are still kind of making the argument that that's even still not
too straight. I agree.
enough, you know, in terms of and even debating that it's a misnomer to call it attention deficit, because it's not the attention that's deficient, it's executive function disorder is the argument that is a better name.
Absolutely. And I'm with them, because I say our problem is not deficiency of attention, it's because we're too attentive in everything. That's the problem. Like we're like little squirrels. Like we're too attentive, we're too focused on everything instead of focusing on what we need to be focusing on. That ability to be able to distinguish, right, is really part of our executive dysfunction that we have. So that being said, with like, you know, okay, so we have this diagnosis criteria, and as a pediatrician first before pediatric cardiology, I remember in Gen Peds then, you never needed to go to a neuropsychiatrist or anything to get diagnosed. All you had was like a checklist from your teacher, a checklist from your parent. If you met the criteria, you were diagnosed. But I'm finding out these days that a lot of people are wanting people to go to a neuropsychiatrist or a neuropsychologist to get diagnosed first, what is the appropriate, like if someone says, I suspect I have ADHD, what is the appropriate way to go about it?
Thank you for asking that. Actually, that's important. And that's something that's come up for discussion in a lot of even the psychiatry groups. ADHD is a clinical diagnosis, and it's really not, you don't really require a neuropsych eval to get a diagnosis. However, you do need someone skilled doing your assessment. And if many psychiatrists are honest with ourselves, a lot of people are not skilled in doing the diagnosis. So I think the neuropsych eval is a way for people to have a psychologist or psychiatrist who maybe has some more experience doing these things, doing like the specific assessments for them to lead them, or maybe to help rule out people who may not meet criteria. But a lot of the experts in ADHD absolutely don't think that neuropsych eval is not needed, is not required, has a lot of false positives, and doesn't necessarily cover everything that needs to be covered. Also,
and
there's a barrier.
Negatives, I've seen too. Yes. Absolutely. So, sorry to cut you off.
No, absolutely. No, that's important. Yeah, lots
Hashtag of ADHD.
I don't trust them. I don't trust the neuropsych evals for ADHD now anymore, because everyone, I feel like everyone can meet some of those criterias, and if you do not place them in context in terms of life, it's easy to get muddled up. There's also the barrier, right? Not everybody can afford these neuropsych assessments. They tend to be very expensive. But the other downside of it is that to do a proper clinical diagnosis, I would say it takes more than one visit. I like to get to know a patient over several visits to get all the information, because the insurance system as we have it right now doesn't really allow for a lot of time. So people don't feel confident in their diagnostic skills, because if you're seeing people in a short amount of time and you have to come up with an assessment within 30 minutes to an hour, your assessment is garbage. I mean, sorry, but it is. So people are using neuropsych eval as a tool to help them gather information, but ideally to do it, I do think you do need several hours of visits, meetings, getting all of the information that's currently recommended. And really, if you can do that, neuropsych eval is really
not necessary. I am so happy you said that, because I've had some clients come see me, and I do consider myself a ADHD expert, and in me talking to them, I'm like, you have it. Like, you have it, and they're like, but my neuropsych eval is negative. I'm like, based on what you're telling me right now, and based on all the symptoms, when you've always had this all your life, it's just not happening now, because there are things that happen, right? Like we get executive dysfunction type symptoms, like when we have a new baby, right? That's not the best time to get evaluated.
Well, that's when you're going to be super scattered too.
Exactly, So I've had people tell me, but my neuropsychology said based on this, but what if that day you prepared yourself, you had a good night's rest, you were like at the bed, because your days are hyper-focused. And I'm like, whoa, do I even have ADHD? Right. And then most days are not. I'm like, yes, I need to do what I need to do to get on my medication or get myself together. But at the same time, I just want people to realize that I don't think everybody has ADHD. I'm not one of those people that feels like everybody has ADHD. I do think you need to go see someone who is skilled and who can diagnose you. But at the same time, don't let money be a barrier to get yourself diagnosed. If you can see a psychiatrist and go through multiple visits, get to know them. Dr. Bolanle is in New Jersey. If you want to connect with her, I have all her information.
We cover Jersey and New York.
And New York. So you cover New Jersey and New York, and you do virtual.
Virtual, yes.
Okay. And she does virtual as well, right? So these are like psychiatrists who understand the diagnosis. And even though she doesn't think she's an expert, she is an expert. So get to talk to them and get to know them, and then they could give you a more objective measure of what's going on. Because there are times, as we all know, anxiety sometimes can present as ADHD. ADHD can present as anxiety.
Absolutely.
Depression sometimes can. And a co-occur, right? So what I actually, maybe it's because I'm MD, I actually feel like one of the best places you can go is with a psychiatrist, because they can help you piece out, is it together? Is it co-occurring? Is it anxiety? Is it ADHD, or is it ADHD causing anxiety, or is it both at the same time? Those are things I think are very important to kind of know about and learn about. All right, so
Absolutely.
that's a diagnosis, and I'm so
Okay.
glad you mentioned that.
Thank you.
So for the lay people going around, you said it's a clinical diagnosis. And for people, when we say clinical diagnosis in medicine, what that means is that it's based on what you tell them, right? It's based on what you are experiencing. It's not like yes, there's some tests you could take, but there's
Right.
no specific blood work we could take and say,
Right.
okay, you have ADHD based on this blood
Exactly.
diagnosis. For example, like diabetes, right?
Right.
Diabetes, I could get some blood work and say, based on this A1C, you are diagnosed with diabetes. So when she
Right.
says clinically, that's what she means by that. And when she says over time, like I had a family tell me, well, when my son just went to the doctor, they were just diagnosed. I was like, not necessarily, because when your son was younger, they gave you something to fill that the teacher filled. And the teacher has experienced your son over several days and weeks, even more than most people would think. And you have also experienced your son for years, right?
Right.
So they're taking those information and bringing it together to make
Absolutely.
the proper assessment. So
Right.
that's that.
That brings us to an important point. Actually, sorry, Dr.
Yes,
Lola, that I'm
please.
interrupting you.
Go
Because
ahead,
for
girl.
the proper, like the guidelines for proper assessment actually requires that you do the a structured interview, if you can find the time, that is more inclusive and robust. But also there's the informant piece of the interview, which is where you gather data from either a parent, a teacher. And I think it makes the children's diagnosis a bit easier, because most children have access to a teacher and a parent or a guardian who can really fill in the gap. Because ADHD people with ADHD can underreport their own symptoms, right? But your spouse will be like, oh, he like, his room is a mess. He leaves everything everywhere, has stickies everywhere to manage. Like your spouse would just give you all of the data that would be like, oh, that's it. Like I had a man who was talking to me and it was like driving in circles and it was jumping up the walls, and I was sure, and I was like, can you get me your mom? Can I talk to your mom? And we talked to the mom and was like, I don't need any more information. We're done. We have a diagnosis.
We're done. You're diagnosed.
Everything like he didn't give me, because we don't like to talk bad about ourselves. And a lot of people with ADHD think of some of the symptoms as something bad about themselves, right? So it's not the first thing we tell people when we meet them. But the parent or the spouse will offer that information that
or
really
don't even realize it, right? Because I remember with mine, when my when the psychiatrist was going through things, and he was like, oh wow, how did you survive medical school? And I was like, I was fine, I don't think I have it. He was like, okay, so how did you study? I was like, well, I can't really focus, so I would go to the library, and then I did this and I did that. And so I had all this masking thing I was doing, and he was like, do you really think everybody does that? Like, so because we've maxed it so well and we've created strategies, we sometimes think we don't have it, so we underreport sometimes too because of that. So do you mind telling people what's the difference between a psychiatrist and a psychologist? Because I've heard people miss this, and I just want you to explain.
That is true. Thank you. So we have a psychiatrist is a medical doctor, a physician that usually does the regular medical training. So an MD, like every doctor, every physician starts as an MD or a DO or an MBBS if you're in Europe, the basic medical training, and then specializes in mental illnesses. So a lot of psychiatrists will look at things from the physician perspective, and physicians are also psychiatrists are physicians, and we prescribe medications as part of our treatments. Psychologists are the degrees they usually have a PhD, and they focus more on study of psychology development, and they're very well versed in the theories. Psychiatrists get a little bit of the theories also in our training, but psychologists, that's their area of expertise. When you look at Dr. Freud and a shrink that's featured on TV having people lie down on a couch, that's you're typically like a psychologist, and they don't tend to do meds. There's a lot of overlap in our work. We work together a lot in the field, but I'd say that's the main distinction, like track and training.
Right. Awesome. Thank you so much for that. So the main thing is the psychologists help with like some of them do coaching too. Some of them do therapy. Some of them do
Yes.
CBT, which is
Yes.
cognitive behavioral therapy. But a lot of times, like I always say to our community, we ADHD, I believe in a holistic approach, right? You need the strategies, you need the therapy, you need the coaching, and you may or may not need medicine. I'm an advocate for medicine if you need it, help yourself a little bit. Sometimes you may need medicine to start off and then you get the strategies on, and you may not need it long term. Because I think the fear a lot of people have is like, once I get on medicine, I'm going to get hooked. And, I'm going to be a druggie. Like we have, so that leads me to my next question. Can you talk a little bit about the ADHD class of medication and stimulants, non-stimulants, and just overall?
All right. So ADHD is currently conceptualized as a condition, so as a brain condition, right? The brain develops that way. It's not, something that happened. It's just how the brain develops, in a way where dopaminergic pathways and norepinephrine pathways are functioning different than the neurotypical people, and that's just how the brain, develops and forms. So a lot of the medications, so apart from dopamine and norepinephrine, there are other pathways that are implicated as well. The alpha agonists, for example, help mediate some of the communication in the brain, and that's looked at. So anyway, because of these pathways, a lot of the medicines that are used to treat ADHD are ones that aim in one way or the other to increase the signaling for dopamine as well as norepinephrine in the parts of the brain where it's needed, like the prefrontal cortex specifically, which is where kind of the executive function, the seat of executive function, and the part that's thought to look different. Well, there are different parts of the brain that look different for people with ADHD than people that don't have ADHD, but the central basis of it is messaging, right, by neurotransmitters, dopamine pathways and norepinephrine pathways. So the biggest class of medicines, the most effective medicines for ADHD, first line would be, for adults anyway, would be the stimulants. And there are really two major classes of stimulants. So it would be the amphetamines and the methylphenidates. And then within each class, so the methylphenidates and the amphetamines, and then because they're salts, they have like two types of them, the D's and the L's. They're just like mirror images of each other. So under each class of the methylphenidates and amphetamines, you would have like the dextro amphetamines, for example, and on the methylphenidate, you also have the dextro. And then you would either have the mixed salts or the dextro. I hope that wasn't too confusing the way I said it. But those are kind of the big classes. And pretty much every medicine, every stimulant that you could ever be offered will fall under. So I've broken the two into four. So they would fall into any of those. For adults in general, the preferred selection would typically be for the longer acting agents for daily use. And this is because if you look at the neurobiology of how things work, we don't want to increase dopamine in sharp several bursts. We want to increase dopamine release. We want to provide dopamine in a slow, steady, robust way throughout the day. That is how it's been studied and thought to be most effective and helpful. Anytime we go outside of that and we're doing short bursts, that's when the propensity for reward. So when we do short bursts, that's when we stimulate more like the nucleus accumbens, which is kind of our reward pathway, and we overstimulate at a time, and that's where the potential for addiction occurs more likely.
Interesting.
When we're doing the short bursts. So the best ways are the formulations that release over a period of time.
So the long acting ones.
And the long actings, that's where we want to go. So again, I can give you trade names, but everything you could, and the other difference would be in terms of delivery. So a lot of the pharmaceutical companies work on how to deliver it. We have the capsules, We have the capsules that you can break into powder and use if you can't swallow pills. We have the extended release. We have the patches for people who can't take pills. We have the different types of salts that really just focus on the release, because the key for treatment is in the release, how well it's released and, slowly into the system.
Okay. So what about the so we have the stimulants. What about the non-stimulants? How do they work?
Thank you. So I almost forgot that. So the stimulants are the first class. The other classes that we would look at closely with that is the alpha agonists. So the two major ones for that would be clonidine, and the other one would be Intuniv. And there's a new one whose name I'm blanking out right now. I want to say Kelpri. I'll if I remember, I'll say. But there's a third one that was recently approved. I'm not calling off the name right now. But essentially, the alpha agonists work by decreasing the hyperactivation, which is a big part of the ADHD experience, like the overactivation, the stimulation, the running thoughts, I think is how people experience it, or restlessness, or the hyperactivity. The alpha agonists tend to quiet that down for a lot of people. So that's how it's used. So it works that way, while the stimulant is increasing or improving dopamine and norepinephrine stimulation. The alpha agonists also potentiate or mediate the norepinephrine activities as well. So they're typically either used in conjunction with the stimulants or alone. Sometimes they're used alone, especially in children. So if a person cannot tolerate stimulants, then they may be able to be treated with alpha agonists. Again, the stimulants are the first line, but sometimes people can't tolerate it. Sometimes it makes people restless, right? We have a lot of side effects to be concerned about for people. There's decrease in appetite. There is worsening of anxiety for some people. There is what else? The internal restlessness for some people. There's risk for psychosis, depending on if someone has other underlying illnesses. So for whatever reason, if a person cannot use stimulants or cannot tolerate stimulants, or stimulants are just not appropriate for them for some reason, then we would consider the alpha agonist. Also, so those are kind of like the FDA approved classes. The other classes also that we look at, since what we're trying to do is improve norepinephrine stimulations, we have other norepinephrine medications already on the market, right? All the antidepressants, they do serotonin. Already, we always had them. The difference is that they're not specific, right? So when we're stimulating serotonin with the stimulants, they're being very specific. They're in where they go and how they act. The SSRIs are not selective. They're broader. They're doing so the SSRIs, the SNRIs, the tricyclics also, they have activity. So people use them off-label if some people find them tolerable. So you would see effects are being given. There's also bupropion, Wellbutrin, which is kind of like a less potent methylphenidate, because it also activates dopamine and norepinephrine. So I tell people like that's kind of like a low-grade stimulant is how I describe it to people. It does the same thing, but not as potently as the stimulants does. So bupropion is an option for people who don't want to go for stimulants. I've mentioned the SNRIs. Oh, there's also modafinil and Nuvigil, which is not really FDA approved for stimulants. They're originally used to treat disorders of wakefulness, so like narcolepsy, sleeping disorders. But again, the wakefulness, the areas of wakefulness also have a role to play in ADHD. So people use them off-label as well to treat ADHD when other things don't work, where the first-line medications don't work. So I'd say those are the major classes that are used in treatments.
So that just seems like a lot of medications, and the layperson's like, wait a minute, I didn't even know there were that many medications out there. So what I'm gonna say is that this is why I think it's very important to be with a physician that understands ADHD, especially if you have comorbid condition, right? Like what I mean by that is if you have ADHD and possible other things. So if you go to a psychiatrist, they can potentially pick a medication that can treat both, And another thing I've heard from people is like, I tried medication didn't work. So I stopped using medicine, and they assume there's only one medicine, which a lot of people think, oh, my stimulant didn't work, which is like methylphenidate, it didn't work. So I stopped. My Concerta didn't work. So I stopped. But there's so many different classes of medicine that may work. And there's sometimes where some classes work for you when you were younger, and now that you're older, a different kind of class may work better.
Right.
So I always encourage people to at least talk to their psychiatrist, and they can better understand, because the amazing thing about psychiatrists is like they're just not giving you medicine, right? They're also digging in your diagnosis.
At
So
least
like
they should be.
good point. Good point. Good point. They should be digging in your diagnosis and making sure you don't have other things going on, and to help you. The last thing I want to ask is like people who are scared of tolerance. Like I've had people say, I don't want to take medication because I don't want to be addicted. We have a lot of like drug addiction in my family. What do you say to those people?
I would say that, what do you call addiction, right? Because when I ask people and say, what are you calling addiction? They're like, oh, I'll have to, take it for the rest of my life to function. And my question is, if you had diabetes and you had to take insulin for the rest of your life, are you going to say you're addicted? Well, usually I get it, but that's different. And I got to say, well, how's that different, right? It's a medicine. If something is not functioning optimally for your life, if you need to take it, you're not, taking it in an inappropriate way. You're taking it in a tested way, in a controlled way, with someone who will hold you accountable. If you need it, you need it. If you need blood pressure medicines, you need it. So you take it for you. And I also wanted to add that the addiction at the doses at which they're prescribed under the FDA, remember, the FDA keeps a tight leash on these meds. They don't want people like getting addicted and running into trouble with it. So if you're taking it within the parameters of the FDA guidelines, you're not taking it in the addiction realm. It takes very high doses to stimulate enough to touch the nucleus accumbens, to do the extra releasing, the flooding that it takes to get excess euphoria, and then the need to, the addiction process, the reward system. It takes high doses to really get there. So if you're using it within prescribed guidelines under supervision, I would say then you're using it to treat an illness like you would any other medication.
I just love you saying that. Thank you so much for that, because I have tried so hard to tell people, but they don't listen. But I figured if it's coming from a whole psychiatrist, they will finally understand what I've been saying about that. But Dr. Bolanle, I could talk to you all day, all night, but we have to go. So, but before I go, I always ask my guest, if there's one thing that you want the listeners to take out of today, what would that be? Like, if there's just one thing I can remember, because hashtag I have ADHD, I'm not going to remember anything. But if there's one thing you really want them to take out of our discussion today, what is that one thing?
It is that ADHD is a neurodevelopmental disorder. And that means that your brain developed that way and different from everyone else. And so you're going to have to develop tools that function, that work for your brain the way it functions in this society. Because this society is not set up for the ADHD brain.
Absolutely. Absolutely. And I just can I do like a bloop? Because I say that all the time. Bloop. All right. So how can people get a hold of you, Dr. Bolanle? Because I know people are listening like, I have to reach out to her. How can they get a hold of you?
So to reach out to me, I can be found on social media. Like I put out videos and like talk. I don't talk a lot about ADHD. We may start talking a lot more about it as well. I'm at Dr. Dr_Bolanle. That's BOLANLE. I'm also at BrightMindsMD Live on Facebook, which is where I share some information. And of course, my practice is BrightMindsMD, which is BrightMindsMD.com, which is a website where we put information for treatment for the public. Those are 3 places.
Awesome. Thank you so very much for coming. I appreciate you. It's been an amazing conversation. And for you listeners, I just want to thank you again for joining us for another amazing episode of LollieTasking with ADHD. We will have all of Dr. Bolanle's information in the show notes below. So just go ahead and scroll down, click follow her, contact her, set up an appointment to see her. And everything will also be on our website. Don't forget to also follow us at LollieTasker or email us at hello@LollieTasking.com. Till next time, remember you can do it too. Some planning, a little bit of balance, and a dash of determination. This is LollieTasking with ADHD. Thanks for hanging out with us on another episode of LollieTasking with ADHD. If you like what you've heard today, I would love for you to click the subscribe button, rate, and leave a great review, in addition to sharing with your friends. Your review allows visibility and also allows other amazing women to find this podcast. Also, if you have any questions or topics you would like for us to discuss, please contact me via direct message on Instagram at LollieTasker or email us at hello@LollieTasking.com. Till next time, this is LollieTasking with ADHD.